In Chapter 49, we're going to discuss disorders of musculoskeletal function that include some of the developmental and metabolic disorders. So, skeletal disorders may develop because of abnormal growth and development processes, because of hereditary or congenital influences. So, we'll talk about a few of those. And there are other skeletal disorders that happen later in life because of things like nutritional deficiencies or disorders to metabolism or hormonal influences, or just kind of the overall aging process. So this chapter is really divided into kind of those two parts, those that are altered skeletal growth and development that we see in young people, and those that are metabolic related bone diseases. So we're going to start with a discussion of bone growth. So in normal bone growth, long bones grow in length. The deeper layers of cartilage cells in the growth plate, or what we call the epiphyseal plates, start to multiply and enlarge, and they push that articular cartilage further away from the metaphysis and diaphysis. So you can see that kind of here, those like middle and distal portions of the bone. Um, and so as that happens, as that kind of cartilage is continuously synthesized at the end of the bone near the epiphysis, that cartilage is synthesized and then it starts to calcify or harden. Osteoblasts or bone building cells invade the area. So there's always kind of this active bone formation at that between the metaphysis and the epiphysis that allows those long bones to kind of continue to grow. But there are things that can interrupt that normal bone growth that we see. One of them is scurvy, which is a vitamin C deficiency that can impair the formation of that organic matrix of bone. It slows growth at that epiphyseal plate and decreases the overall diaphyseal growth that we see in a long bone. We're going to talk about the condition called rickets later on, which is a vitamin D deficiency that prevents calcification of that new bone that's occurring at the growth plate. Absence of thyroid hormone can impair growth. Absence of growth factor can impair growth. Absence of insulin can also impair growth. Another issue with bone growth can happen if there's separation of the epiphyseal growth plate. That can happen in things like fracture or trauma to the bone. If those blood vessels that nourish the epiphysis are damaged, it can cause complete cessation of growth and cessation of lengthening in that long bone. So some other hereditary and congenital bone deformities that we're going to talk about are osteogenesis imperfecta, developmental dysplasia of the hip or DDH, and we'll also talk about clubfoot. So osteogenesis imperfecta is a condition that causes extreme skeletal fragility. It's a hereditary disease and it interferes with collagen formation in the bone. So you can see that kind of on this x-ray here where we have bones that are extremely thin. There's a lot of like kind of transparency to this bone that shows kind of an overall maybe lack of ossification and hardening of the bones themselves. So these bones are extremely prone to fractures. So the common clinical manifestations of osteogenesis imperfecta are multiple bone fractures. There are several different types of osteogenesis imperfecta. They are all kind of listed in your book with a lot of the individual clinical manifestations. They all have the clinical manifestation of bone fracture and skeletal fragility, but there are some cases of osteogenesis imperfecta that are so severe that they result in either stillbirth or death in early infancy. We're actually seeing these bone fractures occurring in utero. So even while before the child is born, they're experiencing fractures and bone damage. Other clinical manifestations that we see, many of these children develop hearing problems because they have changes in deformity to the bones of the inner ear that are responsible for conduction of sound. They often have dental problems, their teeth don't develop properly, skeletal deformities are common, and they also have really slow kind of growth patterns. So prevention and treatment of fractures is the hallmark of treatment here. We cannot really reverse or change osteogenesis imperfecta. When fractures do occur, they can be very difficult to heal. So the treatment for these fractures is often surgical in nature to make sure that we have good kind of bone alignment and union for healing. Another congenital bone deformity is developmental dysplasia of the hip. So this causes hip problems in infants and children. The hips are usually unstable. They can be malformed. They can be what we call subluxated or completely dislocated. And you can kind of see the difference here in the pictures. This is how a normal hip bone would sit in the pelvis. This is a subluxated where it's partially out. That hip is partially out of its alignment, and then dislocated where it's kind of completely out of alignment. DDH has hereditary, environmental, and mechanical causes. So we're looking for maybe a positive family history of DDH because often that is related to like a general kind of laxity or like loosening of the ligaments that attach that hip bone. You can kind of see them here in those pictures. But one of the congenital issues is that these are kind of loose or more like lax that causes that hip to kind of pop out. There are, again, some mechanical causes too. Difficult birth, small birth canal. Those are some mechanical causes of DDH. Another thing that we see with DDH is that it's more frequent in girls. We think that it's probably related to maternal estrogens and other hormones that are causing that pelvic kind of relaxation of the ligaments in those infants. Again, things like fetal positioning or a tight uterus that prevents fetal movement might be other mechanical causes, or things like breech delivery. Early screening and diagnosis is really essential in DDH to prevent any further damage to that hip bone itself. And the earlier we can diagnose DDH, the more easily we can treat it, the more easily we can kind of realign those hips to prevent further problems later. Treatment at any age includes reduction of any dislocation. So we'd have to get that hip kind of moved back into that seating position. And then immobilization. And when we immobilize the legs in what we call an abducted position. So you can see that here where those legs are abducted or moved kind of away from the midline of the body. We do that usually with something called a Pavlik harness that's kind of hooked around the shoulders and around the chest of the baby, and then straps are used to hold those legs in that abducted position. So as I mentioned, we do screen early. So we usually look right when infants are born for these signs of DDH. So things like asymmetry of the hip or gluteal folds. So the gluteal folds are kind of those little folds right underneath the buttocks that we see. If they are kind of misaligned, one may be higher than the other, that's a sign of possibly DDH. If we see shortening of one thigh, so if baby's laying on their back, if we put their knees kind of up, bend them and put them up, one knee will sit higher than the other. That can be a sign of DDH. Or if there's limited abduction of the affected hip, so we can't pull that or abduct that leg as far from midline as we can on a normal leg, that can be another sign of DDH. This is another common orthopedic condition which is clubfoot. This is something we talked about earlier because it has a multifactorial inheritance pattern, environmental and genetic influences here. This is one of the most common pediatric orthopedic conditions. Um, what we see is a foot that's turned to the side, and the involved foot, calf, and leg are smaller and shorter than the normal side. So you can kind of see that here. We're turned to the side, that leg is shorter than the normal side, and the foot is typically smaller. We might see that in one foot, we might see it in both feet. Either one is possible. Um, Treatment of clubfoot, we want to treat this really early. We want to initiate treatment during the first few weeks of life because we can, if treated early, potentially deal with this in non-operative ways where we do just kind of serial manipulations of the foot with casting to kind of gently correct that deformity. If the deformity is really severe, surgery is an option. Um, or when the non-operative serial manipulations aren't successful. Here's another common orthopedic deformity of growth, which is scoliosis. So you can see that here in normal straight spine, and in scoliosis, we have that kind of lateral curvature of the spine. So the definition of scoliosis is lateral deviation of the spinal column that may or may not include rotation or deformity of the vertebrae themselves. So we have some classifications of scoliosis. There's postural scoliosis, that's a small curve that corrects with bending, and that may not require any treatment at all. And the other is structural scoliosis, where we have fixed deformity that does not correct with bending. So when someone kind of bends over, that lateral deformity remains. And that type is more significant and would require potentially more treatment. So we have different classifications of scoliosis. Idiopathic scoliosis, that's the most common type. Idiopathic can happen at any age, but it most commonly starts in adolescence and is more common in girls. It's a structural spinal curvature which no known cause has been established. That term, idiopathic, we use that term a lot with a lot of different conditions, and it literally means unknown cause. So this is just something that happens. We don't know why. We also have congenital scoliosis that can be caused by disturbance in vertebral development, usually during that 6th to 8th week of embryologic development. So that kind of early stage of development of the embryo. And there's also neuromuscular scoliosis that develops from neuropathic or myopathic diseases. So later neurological diseases or muscular diseases can cause later development of neuromuscular scoliosis. We're going to really focus on that idiopathic type here for our discussion. This picture here shows some of the kind of classic outwards clinical manifestations of scoliosis. So we often see a high shoulder where one shoulder is higher than the other, so uneven shoulders. We see a scapula that may project kind of further out. We see hips that are sort of misaligned. And usually as scoliosis develops, it's really pretty painless until it becomes really more severe. And then usually the pain is due to kind of muscular imbalance if it's uncorrected. If left to go even further without correction, we can start to see cardiopulmonary dysfunction as it makes it more kind of difficult as we see like maybe changes to the overall structure of the rib cage. It can make it more difficult to breathe, can constrict the cardiac muscle. So early diagnosis of scoliosis is important because we want to kind of start to treat that deformity earlier. The earlier we treat it, the less deformity that has occurred, the more successful that treatment can be. We used to do a lot of like really routine screening. We would screen all adolescents, especially adolescent girls, for scoliosis. But that's not really the recommendation anymore because what was happening is we were initiating a lot of kind of unneeded and follow-ups and treatments. So now we usually, we still want to diagnose this early, but now it more closely comes with, usually parents might notice this early on. Like some of the early things that parents might notice is it's potentially, difficult to find clothes that kind of fit because of that shoulder or hip misalignment. So at kind of routine doctor's appointments, we're kind of asking good follow-up questions, screening kids in that kind of venue to look for scoliosis early on rather than just doing kind of all routine screening. Treatment can range from kind of a watch and see approach if it's just really mild. Sometimes kids grow out of it as they grow. Um, we can also use bracing to try to correct the deformity, or even surgery. And all of those decisions are really based on the degree of curvature present. If it's mild curvature, it might be wait and see. If it's mild to kind of medium sort of curvature, we might use bracing. And if it's severe, surgical intervention might be necessary to correct. So those are really the bone growth issues. And now we're going to move on to some more of the kind of metabolic sort of later diseases that we see in bone. So understanding this is dependent on your understanding of the overall process of bone remodeling. And this is going on within our skeletal system kind of all the time. Bone remodeling is the process of kind of skeletal maintenance. And this is happening once skeletal growth is complete. So, usually during the first 2 decades of life, we're seeing overall skeletal growth that stops at that point. But bones are always throughout our lifespan constantly kind of remodeling themselves to make sure that they are, maintained with that good, healthy, strong bone tissue. So again, that's really a continuous process that's going on in the body all the time. And it's characterized by this overall sequence of bone resorption or breakdown, and that's done by cells called osteoclasts, and then formation of new bone to take its place, and that formation is done by osteoblasts. And the overall replacement of bone by osteoblasts should equal the amount of resorbed bone that's happening via osteoclasts. And they have to be equal or in equilibrium to avoid any net loss of bone tissue. So what we see, especially maybe in elderly populations, is that the rate of bone resorption or breakdown and the formation of new bone are not perfectly coupled. And so we get this kind of overall loss of bone mass. So again, equilibrium of bone tissue is that exact coupling of bone resorption and formation that results in a lack of overall bone tissue loss. There are a lot of different things that have an influence on that equilibrium of bone tissue. One is mechanical stress. So things like weight bearing are essential to maintaining that equilibrium of bone tissue. If we do not have adequate weight bearing or mechanical stress on bones, we get more overall breakdown than we get bone formation. Another influence can be the levels of calcium and phosphate in the extracellular fluid. Calcium and phosphate are essential to the mineralization of new bone as it forms. If bone cannot be properly mineralized, it becomes soft, and we do not have that proper kind of bone formation. Other influences are hormones, growth factors, and cytokines. All of these chemical mediators can help to influence that overall homeostasis of bone, that overall general matching of formation to breakdown. So the first thing we'll talk about in that metabolic realm is something called osteopenia. Osteopenia is a condition that is common to all of our metabolic bone diseases. Osteopenia is not really a diagnosis, it's a term that we use to describe the lack of bone seen on things like X-ray studies. The major causes of osteopenia are osteoporosis, osteomalacia, malignancies like multiple myelomas. Different endocrine disorders can cause osteopenia like hyperparathyroidism and hyperthyroidism. So the definition of osteopenia is a reduction in bone mass greater than expected for someone's age, race, or sex. causes decrease in bone formation. It can be caused by inadequate bone mineralization, or it can be caused by excessive bone deossification or bone breakdown. So one of the first common causes of osteopenia is osteoporosis. And osteoporosis is a skeletal disorder characterized by the loss of bone mass and overall deterioration of the architecture of, bone and subsequent increase in bone fragility and susceptibility to fractures. So we're getting this loss of mineralized bone, and it causes our skeleton to be more porous, and that's what leads to this bone fragility and fracture. Osteoporosis can occur as the result of different endocrine disorders or malignancy. We see risk of osteoporosis with things like long-term use of corticosteroids. So there are some non-aging related causes of osteoporosis, but the most common cause and the most common thing it's associated with is the aging process. So osteoporosis is a metabolic bone disease. It's characterized by an overall loss of mineralized bone mass, causes the bones to become more porous, and it causes people to become susceptible to fractures. So some risk factors associated with osteoporosis, there are some personal characteristics. We see osteoporosis more commonly in Caucasian individuals, more common in older individuals. Women tend to be more susceptible to osteoporosis. People with overall small bone structure or small frames tend to be more at risk. Postmenopausal women, there is protection that is given by estrogen, and as estrogen levels drop in after menopause, we lose that overall protection of the bones. More common in families, so a positive family history is also a risk factor. There are lifestyle characteristics as well. So sedentary individuals who don't have that kind of mechanical stress on bones are more susceptible. People with calcium deficiencies, those who have a high protein diet or with excessive alcohol, caffeine intake, or those who smoke are more likely to develop osteoporosis. There are drug related causes, the most common one being corticosteroid use, and certain diseases can predispose. So Cushing's disorder, thyroid disorders, those who are diabetic, people with parathyroid disorders, malabsorption disorders. So those are disorders that would prevent the absorption of things like calcium and vitamin D from the diet. So those can be things like celiac disease. Alcoholism can predispose people to the development of osteoporosis. Another one that we're seeing a little bit more is what we call the female athlete triad disorder. So this is a disorder that has a pattern of disordered eating and maybe excessive exercise, generally that we see in women, that leads to the loss of periods or amenorrhea. And that can lead also to osteoporosis. So again, it's poor nutrition combined with intense training. And what it's doing is it's decreasing this kind of critical body fat to muscle ratio that we need in women to control the menstrual cycle and the estrogen production of the ovaries. And so if we lose that normal estrogen production, remember we said that estrogen is protective of bone mass. Now we lose that estrogen related production. So we can see some early osteoporosis in female athletes that go through that kind of female athlete triad. So diagnosis and treatment of osteoporosis. So BMD or bone mineral density assessment is recommended for all women over the age of 65, regardless of risk. But we also might recommend bone mineral density testing for those younger than 65 if they have significant risk factors. So those are things like delayed onset of menses, so after maybe 15 years or later, people with really low body weight, so people who smoke, people with a history of fractures, or people with a history of early fractures, maybe in a parent. Treatment of osteoporosis, things like regular exercise, especially weight-bearing exercise. We want to maintain adequate intake of calcium and vitamin D. We want to do that really early, especially for prevention of osteoporosis, and especially in women pre and perimenopause. So again, weight-bearing exercise, walking, jogging, rowing, weightlifting, those can all be important exercises for the maintenance of bone mass. And then there are also some drug treatments, and you guys will probably talk about these in pharmacology. So there are some anabolic agents that you guys will discuss and some anti-resorptive agents to prevent kind of that bone breakdown that you guys will, again, talk about in your pharmacology course. So in contrast to osteoporosis, which causes kind of this overall total loss of bone mass and overall brittle bones, osteomalacia and rickets are conditions that produce a softening of the bone. We don't have an overall loss of bone matrix that is usually still intact, but the bones themselves are much softer. So osteomalacia is a generalized bone condition where we see inadequate mineralization of the bones, usually resulting from a calcium or a phosphate deficiency or maybe both. Osteomalacia causes bone pain and it can cause fractures. The treatment of osteomalacia is usually nutritional. We try to replace or increase the adequacy of calcium and phosphate so that we can start to like remineralize and strengthen those bones. Another disorder causing softening of the bone is a condition called rickets. It's also a metabolic bone disease characterized by a failure or delay of calcification in that cartilaginous growth plate in children. So this happens in children whose epiphyses or growth plates have not completely fused. So remembering back to our discussion of how overall bone growth happens, we have that constant kind of like addition of cartilaginous material at the epiphyseal growth plate, and then that cartilaginous material is mineralized to cause it to kind of harden or ossify. And so if we can't mineralize bone during that growth period, we get kind of softening of the bone in general. So rickets is a disorder of vitamin D deficiency generally that causes inadequate calcium absorption, which impairs the mineralization of the bone in children. So that vitamin D deficiency might be happening because of conditions like kidney failure. It happens if there are malabsorptive diseases like celiac diseases. There are certain medications that we give children. One specific one are anticonvulsant medications that can cause this. Or it might just be an overall inadequate intake of vitamin D or sun exposure. Rickets is seen more commonly in developing countries, not as common in the United States because of vitamin D supplementations and things like milk or cereals. But the characteristics that we see with rickets are bone deformities. If it's happening in infants who aren't weight bearing yet, it might be things like fontanelle closure failure, slow developing teeth. Once children are able to weight bear, we see it manifest itself in what's called lumbar lordosis, which is kind of a curvature of the lower lumbar spine. And another common thing associated with this is this bowing of the legs, and that's what you're seeing kind of in this picture. So the softening of the bones themselves combined with weight bearing causes this overall bowing. So treatment of rickets is typically dietary in nature, so dietary interventions, vitamin D, supplementation and calcium supplementation, and then we can try to correct some of the changes with maybe bracing or postural correction. And the final metabolic disease we'll talk about is Paget's disease. So Paget's disease is a progressive skeletal disorder that involves excessive bone destruction and repair. So it's characterized by local areas of this excessive bone turnover with disorganized osteoid formation. So we have regions of rapidly occurring osteoclastic bone resorption, followed by these periods of kind of hectic bone formation. So we have increased numbers of osteoblasts that kind of rapidly come in and deposit new bone in this really kind of chaotic manner. And that newly formed bone is really of poor quality. It's what we call disorganized rather than lamellar. So this is normal bone formation, and you can see that it's kind of like stacked. It's sort of in these kind of distinct lines, and that adds kind of overall strength to the overall structure of the bone. In the case of Paget's disease, those osteoblasts are just depositing new bone in this really kind of chaotic and non-structured sort of pattern. And you can see that sort of in this insert here, where there's just kind of this disorganized matrix of bone production, not in this sort of definitive linear or lamellar kind of construction that we see in normal bone. And so because that bone that's developing is of really poor quality, what we see in the clinical manifestations of someone with Paget's disease are kind of bowing or structural changes to the bone. So you can see that here in my picture, kind of this femur that's sort of starting to bow. We also see that like in the pelvis, we can see it in the cranium, especially areas that are like weight bearing, we get this kind of bone deformation. And then the other thing that can happen, of course, is fractures because that bone is not as kind of strong and of good quality as we see in normal bone. Etiology, we're not really 100% sure what causes this, probably a combination of genetic and environmental influences. We diagnose it based on maybe the presence of some of these characteristic bone deformities, and we might also see overall changes on X-ray. This is often a painful condition, so treatment may focus on reduction of pain. Most commonly, pain reduction is done through nonsteroidal or other anti-inflammatory agents. Um, the pain is really caused by this constant new depositing of bone. All of that constant bone buildup is what's causing that pain. There are also some agents that might suppress that turnover of bone, like biphosphonates or calcitonin. Those can be used to manage pain or prevent further spread of the disease. Um, Biphosphonates are a drug you guys will talk about again in pharm because they're usually used to treat osteoporosis. Um, Sometimes providers prescribe them for other conditions, bone density.